Hey, welcome back. So last week we talked about two different kinds of strokes. We talked about blockages and bleeds in our old gentleman who came in weak. We talked about the possibilities. He had a little bit of kidney failure. His electrolytes were off. He needed fluids. I think he also had a urine infection. Again, all of these things can be treated and he will perk up. He'll look a little better. But the real story that I was getting into was with him and between him and his wife, again, who I really respected as a caregiver. She really loved him, did a great job. You know, tough hand to be dealt, to only be with somebody for a couple years, or even if you're with them for decades, and they suffer a huge health calamity, and then, let's be honest, you're stuck with it. Till death do you part, and in sickness and in health, and I really admired her. What made me start to wonder what's she really bringing him in for? What is she really worried about? These kind of questions that kind of really get at why people come in. Most of the time people are fine and they're afraid. They're worried about something, and that's kind of where I think the real art of medicine is important, that I've learned over the time. It's not about CAT scans and blood work and medicine as much as it's often about really listening to what people need and being there for them and giving them that. So my question, for her kind of was, what are you worried about? What's going on with him? Why'd you bring him in? What are you really worried about? And this was in Spanish, by the way. So there was, my Spanish is pretty good, but there was a little bit of, it took a little more to kind of get through to what was going on there. But really, just kind of, cut the chase with this. This guy was, like most people, an active man. I mean, he worked in the fields, and after his stroke, first of all, after his bleed and then his stroke, he could barely get around. He's getting around in a walker. Certainly not as robust, active, able to not only work, but live his life. I mean, what a huge, huge change. Can you imagine your life, like how drastically that would change? And I just think about that a lot for both of them, for both of those people, not only him, but then her life became taking care of him. And so she came in, and I could tell, and this is very, very common, that she was looking for some respite herself, some relief. I mean, she's with this guy 24/7, taking care of him, bathing him, wiping his bottom and all this stuff. And they didn't have a lot of family in town. And but why was she? Why did she really bring him in? And so she was saying he's not eating as much, he's not drinking, he's just kind of slowing down a little bit, and her fear in there is, is something wrong? Is he going to starve to death? The answer was no. He was not. The guy had enough cushion to live off of. That was not a real thing. Dehydration will cause a problem. And in this case, it did. Give him fluids, treat his infection. He'll perk up a little bit, but that's not really going to address the main issue with her. And finally, I just said, look, do you think he's depressed? He's not eating, he just isn't very active, and his memory doesn't work very well. He's demented. We're getting into, I think, which is the real meat of this thing, which is this is the situation that both of them, that this man is stuck with. He's not the man that he was before. His function has changed drastically. The things that he enjoyed and he could do before, he cannot do anymore. Much more limited. And similarly with her, she was a little bit younger. She may have been in her 50s. She's kind of dealt this card where I'm sure she's depressed too. So I was like, okay, I think she was really there because he was depressed and he was slowly not eating and going down a path where sometimes with strokes and with dementia, that's the natural course of that disease, is that slowly over time you slow down, you get a little worse and worse, and then you pass. And that's okay. I think most of us in medicine don't think that the right thing to do is put in feeding tubes and hook people up to tubes and, stuff like this. It keeps them alive, but the quality of that life, I don't know that most of us would want that if we're honest about it. So we're getting into some of these kind of things, and I think her real fear was, is he getting closer? Is he going to die? And at this point, the answer was no. He's really not that close. The answer was, he's depressed, the guy is depressed. It's hard. It is really hard to, as a doctor, like I've had a lot of these conversations. A lot of times people want a diagnosis. They want dehydration, kidney failure. Let me give you some fluids. We'll make it better. They want something that's reversible. He's got a urine infection. We'll treat that with antibiotics. Great, I love it when I find things that I can fix and I can help people get better and feel better and cure disease, But so many times we come to answers like, hey, I think he's depressed because he's lost this function and he's almost in a wheelchair and his mind doesn't work. I mean, he's got 12 reasons why anybody would be depressed. So we talked about it a little bit, depression after stroke and with age. And of course he was on antidepressants and, all these pills. And let's just be honest, like they didn't do much, Like imagine in that setting, you're throwing this pill at it, like sure, maybe it boosts his serotonin in his brain or whatever neurotransmitter is the, antidepressant of the month, but that's not going to change that situation. And then, so I think it helps to sit down with her to have that conversation. Yeah, he's depressed. What can you do? And she had done everything, taking him to activities and exercise and social. And, like he goes to get social, but he's embarrassed, like sometimes they're in a diaper and he can't move as much. Like social can be good in the right setting, but it can also be very difficult and embarrassing. And a lot of people don't want to go in, they stay. And you can see how this is like the real issue and it's just really tough. And it's a hard thing to work with. It's hard as a doctor to tell them. And then there's the issue of her and kind of ministering to her and how are you doing? Caregiver fatigue is a real thing. In the next video, I want to talk about my grandfather and my experience with that and of how that affected our whole family, my grandmother and certainly me as well. It's really, really hard. And there's often not a lot of answers and there's not a lot of things that we can do to make it better other than call it what it is, do what we can, and then there's just a lot of acceptance. And really the word underneath that is grief and loss and letting go of the person that used to be here that isn't dead, but is not here in the same way and really is partially gone. That life is gone. And so that grief process, in this case, may have been 15 or 20 years in the making with her. And I really think that is probably the real reason why she came in, was not because there was something there that we could fix, but because she was still grieving for him, this life of his that was gone. And so the way to treat that is not as much with IV fluids and pills and antibiotics for urine infection, although that was appropriate for him, but it's really about acknowledging her journey and where it's at and just empathizing with that situation and calling it what it is, which is grief and loss and talking about how we can cope with that and come to terms with it. Heavy stuff, but I think a lot of people out there who have experience with this I think it'll resonate with you. And I thought about them a lot because I thought about my grandfather. So I'm going to conclude this one, and next week I'm going to talk a little bit about my own experience with this as a caregiver of my grandfather, what happened to him, which so much of that kind of came back for me when I was working with this family. So I will see you next week for the next one.